the disruptive disorders called oppositional defiant disorder for both children and adolescents. Primary symptom usually associated with this disorder is the disruptive behavior often displayed by children and adolescents as conflict with authority figures like teachers and parents. It can be seen in one setting, but most likely will be seen in multiple settings, including home, schools, with peers, at the grocery store, and just with any authority figure. Frequently seen in children and adolescents, usually diagnosed around 8 years of age. It can continue to adulthood, but symptoms can often be seen before age 8. It can be difficult to diagnose before this age due to developmental behaviors of defiance seen in younger children. Causative factors including genetic, environmental, psychosocial. There's also a high prevalence of ODD in males than in females. And these behaviors will also be more severe and cause dysfunction in their lives as they become older if it goes untreated. The diagnostic criteria of the DSM-5. Behaviors must have been present for at least 6 months for the following symptoms. They fall into 3 categories and must be observed by someone other than a sibling. 3 categories include angry or irritable mood, argumentative or defiant behavior, vindictiveness, which must be twice within the last 6 months. And with children younger than 5 years old, the symptoms must be present for most days than not in a 6-month period. For 5 years or older, symptoms must be present at least 1 week for 6 months. These behaviors should also be outside of their developmental level. Behaviors also cause distress at home, school, work, and relationships with friends and others. Should be ruled out as not episodic in nature and do not occur only during psychosis, substance use, or a mood disorder. Mild is seen in 1 setting, moderate is at least 2 settings, and severe is at least 3 or more. While getting the information from both the parent and the caregiver, it is important to separate them, speak to the child and the caregiver individually, and collateral information should come from teachers as well. As future providers, it is crucial to differentiate between like diagnoses, such as ADHD, mood disorders, and other disorders that fall into the disruptive and antisocial behavior disorders like conduct disorder that can have similar symptomology. With ODD versus conduct disorder, ODD is known to be the precursor to conduct disorder, and therefore symptoms of conduct disorder tend to be more severe compared to ODD. There are some similarities between both disorders, such as defiance to rules. Both can coexist with other disorders like ADHD and mood disorders, and both can coexist together if both criteria are met. With conduct disorder, more of a physical aggression to people or animals is seen. You can also see destruction of property like starting fires, deceitfulness, theft like breaking into someone's home or car, and other rule violations such as running away from home, staying out late at night without the parent's permission. Another key indicator is whether or not the child shows remorse. If they show no remorse for their actions, I would be thinking conduct disorder. If there is some remorse, especially associated with negative consequences, think oppositional defiant disorder. It is also important to rule out ADHD. Often ADHD and ODD can be comorbid, but it is important to rule out ADHD because of the initial treatment can be different. For ODD versus ODD and ADHD are just ADHD. Both diagnoses usually occur more in males than females, and both can also have irritable mood, which can confuse providers. It is, however, important to rule out ADHD as a primary reason for the oppositional or defiant behavior. With ADHD, irritability will stem from having to pay attention in class, inability to focus, they're unable to organize themselves, having trouble sitting down in the class, which can be mistaken for deliberate disobedience. They can also talk out of turn, intrude on others' conversations or games, which can be mistaken for deliberate acts. For providers, it is crucial to remember that behavioral issues seen in ADHD will most likely stem from their inattentiveness, impulsiveness, or hyperactivity and not come from a place of defiance like ODD. Disorders that are important to rule out include mood disorders such as major depressive disorder and bipolar disorder, which can often co-occur with ODD. Often, irritable or negative mood can be seen in both disorders. However, what sets the mood disorders apart from ODD is that these symptoms will only be seen during a mood episode. If the irritable or negative mood only happen in an episodic fashion, then either bipolar or depressive disorder should be considered and ruled out prior to an ODD diagnosis. Even with coexistence of a mood disorder, the reason it is important to rule this out is that the first line treatment would change, and you would either want to treat the mood symptoms first, whether it would be for using an SSRI for depression or anxiety, or a mood stabilizer for bipolar disorder. The treatment would differ from ODD. It is speculated that the neurobiology of oppositional defiant disorder comes from the dysfunction of the APA axis that involves interactions between the hypothalamus, the pituitary, the adrenal glands, which are also associated with both elevated and low levels of cortisol, which could be linked back to early stress or genetic factors. The theory is that with chronic illness such as ODD, the levels tend to be lower due to chronic activation of the system and inability of the body to keep up. Below, I have included an informative 2-minute video of the HPA axis and the systems involved. Some images gathered from a study done that shows areas of functional changes in the brain. In the study, cases were reviewed of ODD and conduct disorder with and without comorbid ADHD, and structural and functional neuroimaging showed abnormalities in the amygdala, the bilateral insula, right striatum, and the left medial gyrus. These areas are involved with emotional processing, self-control, and empathetic and social behaviors, which can be why children and adolescents with this disorder have difficulty learning social, accepted behaviors that can lead to aggressive behaviors. There are specific changes that can be noted in the brain, therefore, these individuals require prompt intervention and evidence-based treatments for the best results. This case study was a patient that I saw with my preceptor this semester. Patient was an 11-year-old female. Chief complaint, she was being defiant at home, at school. History of present illness, she reported being defiant, angry, irritable, occurred several times per week, behaviors presented for several years but worsened in the past few months, according to mom. Also couldn't tell the truth. Grades were good, but she had a D in math. She pulled her hair, scratched her face when she got mad. Showed no remorse and blamed her teacher for her behaviors, but when we spoke to her individually, she said she lies because she is afraid to get into trouble with mom. Deny any SIHI, paranoia, grandiosity, decreased need for sleep, decreased concentration. And during her exam, she also was not following directions, very argumentative, demanding, defensive, and distracted. With the same 11-year-old, she denied any history of trauma or abuse, denied any history of SI, HI, AVH, traumatic brain injury, substance abuse. Past medication trials included stimulants, denied any developmental issues. Mom said she met her milestones. Father had a history of aggression, substance abuse, and was currently in jail. And family history, brother was diagnosed with ADD, ODD, impulsive control. First line medication treatment for ODD. Generally, medications are not the first line with ODD. Uh, when other co-occurring disorders are ruled out and the behavior starts to become severe enough, and they've tried psychotherapy, doesn't seem effective, medications are warranted. According to the NICE guidelines, second generation antipsychotics have a good reputation for short-term treatment of aggressive behaviors in adolescents. Risperidone was first on the list. Risks should outweigh benefits, and these medications, due to metabolic effects, movement disorders, neuroleptic malignant syndrome, usual dosing range from anywhere from zero point 0.5 to 2 milligrams, and can be used in ages 5 and older. As for psychotherapeutic interventions, for ODD, first line, this is actually the first line treatment, which is parental management training, which is considered the gold standard according to NICE guidelines. It can do individual or group sessions. Group sessions can be up to 10 to 16 sessions and last 90 to 120 minutes per session. Individual sessions are 8 to 10 sessions lasting anywhere from 60 to 90 minutes. The goal is for the parent to change their behavior in order to change negative reactions from the child. It involves quality time with the child, positive reinforcement, timeout techniques, token economy, which uses tokens or points for positive reinforcement that are provided as motivation for demonstrating appropriate behaviors. This can be as simple as just listening for the first time they are told, and they'll get a token of some sort. It also teaches them to set clear and consistent rules in the home and fosters effective communication strategy between the parent and the child. As for the key points, education is primarily the key component, and it's crucial for the parent and the child to be engaged in education about their diagnosis, the management strategies, and any medications and expected or unwanted side effects. Um, Several of my preceptors verbalized the importance of starting their patients, especially pediatric patients, on lower doses and sometimes half doses from the common starting dose. Other key pointers about medications is to use route specific to the patient's needs. This can be as simple as using liquid instead of pills for patients who can't swallow pills. Other strategies is to keep patients and the caregiver informed about treatment plans, goals, and what will change if the goals are not met. This can relieve anxiety about starting new treatment regimen and can reduce discouragement if the initial treatment does not work. For example, the case of a patient with ODD, you would want to inform the patient and the parent that we'll try psychotherapy initially, and if this doesn't work, we'll start medications and give them information about the medications. In conclusion, ODD can be difficult to treat, takes time. Um, it takes an expert in differentiating between diagnoses like ADHD, conduct disorder. Need to know the current diagnostic criteria, use evidence based treatments, be aware of the coexisting conditions and how to treat them as they come. Know the first line treatment is psychotherapy for this disorder. Um, and lastly, treat all the patients with their specific needs in mind. Thank you for listening. If you have any further questions, let me know.